Right, okay. So thanks for inviting me along to give this talk on occupational hygiene and workplace health. I think when I read the introduction on the IOSH website, it was a bit, we weren't familiar with that introduction as to what we were talking about, but I'm sure it'll be covered there and thereabouts within this presentation. Andrea sends her apologies. She's written at least 50% of this presentation, but she's been struck down with illness this morning. She's hoping it's not COVID, but I think her son had COVID last week, so it's probably best that she stays away. So yeah, she sends her apologies. I've took a few slides out of the presentation because they were focused on some of the Office of Rail and Road work that Andrea had been doing, and I can't really talk about that too much. I'll be guessing at some of the outcomes and things. So I apologise for that. But there's plenty within here to have a little chat about. Gary introduced me there and talked about face fit testing because I was involved in the face fit testing guidance, writing the face fit testing guidance. Amazingly enough, I haven't got a slide on face fit testing, but feel free to ask me questions on face fit testing. I spend a lot of my time fielding inquiries to do with that. Okay, so we'll move on. This is me. This is me on an oil rigs not far away from Norway for HSE. That was during lockdown, some years all over the place. So what do I do? Health is pretty much what we look after as hygienists. We look at exposure to health. We take enforcement. We undertake investigations. So this is my HSE role, but as a hygienist. I do onshore and offshore. The offshore is probably going to come to an end shortly. Expert witness reports. So I've spent time in court, spent time writing reports, spent time defending reports, spent time negotiating with other health professionals about who's right and who's wrong. We undertake research. I've been involved in a lot of research in isocyanates, in RPE, of course, in asbestos, in lead, in various hazardous substances, lots and lots of them over the years. Training, involved in training new inspectors and training others as a regional organiser for BOHS. I've undertaken training for other colleagues in the sector. Some of you might be online now, I've got no idea, to be honest. And that ties in with the development of others that I get involved in within my role as HSE and externally as BOHS, and also, going to meetings like this and developing myself as well as other people. So what are we going to talk about today, or what am I going to talk about today? What is occupational hygiene now? I appreciate that quite a lot of you'll know what occupational hygiene is, but we've got a few slides on sort of where occupational hygiene comes from and where it fits in. What do we do? What does an occupational hygienist do? How can we help? How can we help companies? How can we help people? How can we help industries? And some examples of the work I've done. We would have had some ORR examples, but obviously Andrew can't make it today. I'll do a few slides at the end about BOHS, about the British Occupational Hygiene Society. We're very keen to maintain our links with IOSH. So what is hygiene, occupational hygiene? The science of worker health protection, and that's the title we do. Worker health is what we're concerned about. We don't do anything with toilets. We don't do anything helping dentists. I overheard my wife telling somebody once that they asked what Phil did, and she said, he's occupational hygiene. I think it's something to do with restaurants. So I think even my own wife wasn't too sure what we did. So I'm not surprised if people within the industry don't know. Health protection, what we're interested in is the control of exposure to hazardous substances to people. That's the general gist of it. How can we control this exposure? It's not new. Hygiene's been around for years. 1726, control at source for wet grinding. And I mean, there are terms that we use day in, day out. So control at source, wet grinding of flints in the pottery industry. In 1864, every factory should be ventilated. So basically the beginning of LEV, the beginning of extraction. And people say they don't understand it now, and this is what 160 years ago, and it was around then it brought into play. I'm not going to go through all the history of it. I mean, you'll get a copy of these slides. So it's been going on. A big step was in 43, in the early 40s, about pneumoconiosis associated with coal dust. Published a study that, the coal miners are getting really sick, and it proved to be because of breathing in hazardous amounts of dust all the time. There's still coal mines. There's still mines in the UK. Not necessarily so much as mining, doing much mining work, but there is still mines, there's still people under work. I've been down a few, and getting control solutions for those type of places is quite difficult. It's quite really interesting, but quite difficult. So what's the problem with worker health in Britain? I'll give you some of the HSE stats that you've probably seen and you might wish to use. We very much focus, hygienists and health professionals, on health, obviously, not safety. There's usually a slide where you show 99 people who've been affected by health and one person who's been affected by safety at work, because it is the biggest killer. It's 13,000 people die from occupational disease in the past year, over the year. There's 1.6 million workers suffering from ill health. There's 32.5 million working days lost due to ill health. So it's a big deal. And the problem being is that it's not instantaneous. You don't see, I mean, as an inspector, I'm trained as an inspector, and that you then become a specialist inspector who focuses on whatever your specialism is. But we're all trained inspectors. So if we go around factories, for example, and we see, you know, something unguarded, that's obvious. That can be fixed straight away. But if we see an LEV system not in the right place and there's dust going everywhere, that can be a long latency illness. And people, I'll tell you, you're going to get ill, and they say, well, I've been doing this for 20 years, I'm not ill yet. It will happen, unfortunately. Which links on to occupational lung disease. 17,000 new cases of lung disease each year, made worse by poor operating or poor working conditions. This can be, I mean, as health professionals, which are health and safety professionals, which we all are, it's frustrating when you see that control systems can be put in place, but they're often just not. And if they are, they're just not used correctly. And hygienists, it's the control system which is really our bread and butter, and assessing the risk and putting the right controls in place, and then alleviating the potentially hazardous outcome, or the potentially horrific outcome, depending on what the substance tends to be. It can all be done. It's difficult to get people to buy into it, but when they do buy into it, over the years, people are buying into it now. And I'll mention, over the past 18 months, especially with COVID will pop up a few times. It certainly has made a difference with people focusing on health, especially in the offshore industry where I've been working quite recently. So what's the problem with worker health in Britain? Over 36,000 disease notifications for COVID. So COVID, we're going to talk about how disease reports made by the employer. People have been reporting cases of COVID. I'm not going to go into massively COVID now because people are probably sick of it, but it's been noticeable within our industry and within HSE, certain regulatory industry, that COVID is a big issue, and COVID is affecting a lot of workers, and a lot of people are reporting COVID issues. And the problem you have with something like an infectious disease like COVID is that it's deciding or defining whether it was caught in the workplace, and that's where it tends to be an issue. This is an issue offshore, certainly, and it's also an issue onshore. Did you contract it from somebody you live with, or somebody you've been in a shop with, or did you contract it in the workplace? I'm not going to go into a load of that. There's other people far cleverer than me who can talk about the RIDDOR, etc. statistics. So according to the cost to Britain, so cost, money talks, especially in certain industries, and work at poor health or ill health at work costs £10.6 billion according to HSE, the HSE statistics. I mean, and that's an awful lot of money, and that's to do with lost days of work, compensation payments, making changes to make sure people aren't exposed, changing processes, changing substances. The overall cost to Britain is over 10.6, nearly 11 billion when you're talking in those sorts of astronomical figures. So it is a big issue. Health is a massive issue. It's not only the predominant problem for me and for people, I hope, who are listening to this, is, you know, you want people to be healthy. We've all got relatives who work with potentially hazardous substances, so they need to be protected. But there's also the monetary cost to the country, which can be quite critical. So where does hygiene's role fit into this? So we tend to have this sort of diagram, these three spheres, these three circles, called the workplace health triangle, which I'm sure you've seen before. So you have your occupational health on the left and well-being. So managing the health of workers on the left with the occupational health, promoting a healthy lifestyle, and then protecting people from the workplace health risk. That's us, the blue circle. Hopefully it's turning up blue on your screens. That's where hygiene overlaps the two and brings it together. The workplace health risk, so you're not exposed to these hazardous substances in work, with a good health and safety, with a good occupational health policy, good well-being instructions, and a healthy lifestyle, and hopefully we'll all live long. I've gone backwards. So this is a bit of a mixed up, it's a bit of a messy slide, but I mean, you'll see this later on. What I wanted to get out of this one is the lines across the top is what we do, is what a hygienist does, anticipate and recognise the hazard. So what is the hazard? We walk into a place, or you're about to start a process. What will be the hazard? What will be the health hazard? Then you evaluate the exposure. How can I get that into my body? And one of the big misinterpretations really is that hazardous substances are always breathed in. That's often what people miss on their risk assessments, which is the hazard and exposure risk assessments below. It's not just breathing it in. It can go through the skin. It can be injected. It can be swallowed. It can be left on it can be left on surfaces and secondary exposure, etc. These all need to be considered. Often people just say, well, we'll stick them in a respirator and everything will be happy. Then the final part of that line is control and confirm protection. So how do we control the risk? And it might be, for example, everybody's seeing local exhaust ventilation. So an extraction, get the dust away. But there's an important part there, the confirm protection from the risk. So how do you confirm that that is actually working? And that's often a piece that's missed. And I'll go on to a few slides in a minute about competency and external consultants who may come in and say, oh, well, your control systems are working fine, but you need confirmation. You need suitable, competent people to confirm that the protection's working. The same with RPE. You need to know that you're using the right one. You need to know you're using it correctly, and you need to know it fits the person who's using it. So the work profile of a hygienist. So we have hazardous substances and health management issues right there at the top. Health risk management, the blue box below there, that's the important part. I mean, the overall, it's one of the most important parts, the overall health risk management assessment. So how are you going to control health, or how does a person control health on their workplace? Safety, it's not always easier. Safety, you can control safety by, yeah, there's a big guillotine, well, I'll enclose it. There's a conveyor belt with some nipping points, I'll put a guard on there so they don't do it. With health, you know, things can be floating around, things can be on surfaces. How are you going to monitor that? How are you going to make sure that the worker is protected? Now, this diagram's in a few different colours. The blue is the occupational hygienist, typically. The orange is another health professional. However, we do, especially within HSE, we work with the health inspectors, and we work with our medics, so we are involved in all of this. As an inspector, I look at the overall health risk management system. Our general inspectors will look at the overall health risk management system. But we look at air monitoring. You'll have heard of, or you'll have seen, or you'll have been involved in. Who undertakes this? Is it undertaken properly? Control measures, what's in place? Health surveillance, if required, if legally required to do health surveillance for certain substances, then it must be done by a competent person. Maintenance and testing, which I mentioned before, is your LEV tested suitable intervals. Training communications massive in any sort of risk management, not just health risk management. Training communications huge. How you do things, how you fix things if they're broke, what to do. Do you understand how it works? What happens if it goes wrong? Supervision ties in well with that, to be honest, because you need the supervisor or the supervisors or the supervisory position needs to be able to tell people what to do, and needs to be able to tell people that they're not doing it right and identify that. So the hierarchy of controls. This is something that's big in COSH, in the control of substances, hazardous to health regulations, which really are our bread and butter. Elimination, get rid of it. If it's a hazard, if you're working with silica, get rid of silica. It's easy to say, it's obviously not easy to do. Substitution, if you're working with, one example, you have a good example of substitution, chrome 6. Chrome 6 is a carcinogen. If you can replace it with chrome 3, then it's not anymore. So can you substitute it with something that'll do the same job? There was always reductions with that example that chrome 3 didn't give. For example, in plating and chrome plating, didn't give as good a finish as chrome 6, but now it's kind of accepted that it does. Engineering controls, ventilation, general ventilation, local exhaust ventilation, passive ventilation, active ventilation. They're good examples of controlling out. Administrative controls, remove people. If people don't need to be there, or if they can be further away, or they can be stood behind a screen with a remote control. This is all part of occupational hygiene. This is all part of good risk control management. And then the bottom of the hierarchies is always PPE, which is where RPE, as Gary mentioned earlier on, fits in. It's fail to danger. It's the lowest protection. It's always the one we go to last, least effective, because you're relying purely on people to use it correctly. Well, not purely on people to use it correctly, but you're relying heavily on people to use it correctly. So where do we fit in? Where does an occupational hygienist fit in? We're in loads of industries, and The problem with hygienists, there's not that many of us. There's not that many in the industry. There's some who say they are, who aren't very good. But we fit into all sorts of sectors. In the energy sector, obviously the oil and gas, which I mentioned before. Management, overseeing. Not everybody seems to have a hygienist these days. They wouldn't really. But in certain management positions, you have hygienists who will look after sort of reviewing. If you're starting a project or you're starting a process or you're changing it, then it needs to be managed. Defence and Aerospace, Airbus, for example, I know they've got a couple of really good hygienists who are members of BOHS. They really push it. Public services, the military, they have hygienists. We've probably nabbed a few of them to work for HSE. In the supply, manufacturing is the big thing. Manufacturing is predominantly where all your exposures will occur, which we're all familiar with and we all probably work with day to day. So we fit in various sectors. Substances and regulations that hygienists. You might have noticed that I sometimes flip between industrial hygienists and occupational hygienists, and that's in sort of mainland UK, it's occupational hygiene because we are the British Occupational Hygiene Society. When I go offshore, I'm called an industrial hygienist because in the States, people tend to be called industrial hygienists, so people prefer that and don't know what the occupation. I've got to sit on the fence with which one I prefer because I'm a member of the Occupational Hygiene Society. So what do we look at? COSH, obviously. COSH is one of the big things, hazardous substances. COSH is our bread and butter. Recently, the past 18 months, everybody's been looking at COVID, and we are no exception. I've got a couple of slides later on about COVID. We've looking at, because COVID is an infectious disease that can, if your workers are exposed to it, can cause terrible effects and ill health. Noise and vibration, we also get involved in noise and vibration. We're trained in noise and vibration. We're lucky at HSE that we have a lot of noise and vibration specialist inspectors, so I tend to palm off the work to them, but we are trained in to identify these. When I go offshore, I do that myself. Legionella, potable water systems, that's big in various industries, cooling towers, hot and cold water systems. When I'm offshore, I chat with the medic as well. We talk about, we're interested in the health provisions, and I've put medic on there because onshore, if people have occupational health provisions, then we like to know what's going on with the medics, with the occupational health provision. Non-ionising radiation, another topic that we look at. It's not very common these days, but there are some certain processes that are sort of ramping it up a little bit. Food safety is again an issue that we look at offshore. We're trained in this as a hygienist. I've done a master's in occupational hygiene, and this is one of the core things that you look at within HSE. I don't overly look at food safety apart from food safety production, i.e. flour dust and other aspergens and things like that. Welfare, that's something we look at offshore, where the people are staying. It doesn't really, it does come about in certain industries in the UK. I went to a few years ago, a recycling plant, it's a battery breaker, and there's a lead exposure issue, and the welfare was a serious condition there because there was a lot of guys from Eastern European fellows who all lived in the same house, and they were just basically covered in lead and taking it home, and people who didn't have anything to do with the industry were getting lead poisoning because they were taking it into their welfare facilities. Asbestos is a big issue. Asbestos is, everybody knows about asbestos and how harmful it can be, but we as hygienists look into it a lot on the safe management of asbestos. All falls under health risk management, which I mentioned earlier. Competency is one thing that I wanted to talk about as well, about the competency framework and getting competent advice. And I wanted to touch on this, especially from a BOHS and the HSE point of view. As HSE, we deal with we read a lot of reports from health professionals, occupational health and safety professionals, for example, air monitoring studies and thorough examination and tests of LEV. And competency is a big issue because some people just aren't competent to be doing the work that they're supposed to be doing. They might not have the qualifications that that they should have, and the training and the experience, all which falls into the competency framework. So HSE, we take action against these people. There's the thing that winds me up the most is that there's some really good consultants out there, and a lot of people tarnish that everyone was bad consultants, and that's just not the case from my opinion. I love it when I go on a visit and I see a report from somebody who I know is a competent professional, and then I know, I won't spend as much time looking through their report. But some, if they're not, then we'll certainly take action against that. So if you are using a hygienist, you want them to have some sort of hygiene qualification. either a LFOH, a licentiate, or a chartered member. I'm a chartered member. If they've not got them, ask them if they're a member of BOHS. If they've not got that, ask them what their experience is, how they can help, what courses they've done. People often go for the cheapest one, which is not always. There's usually a reason why people are cheap. So my advice is to ask them some questions, ask them the experience in doing what you want them to do before. So if you're obtaining a quote, if you want to look at someone, you can go to the BOHS website and have a look at any hygienist. But I mean, with its limitations, because I'd certainly, as I've just said, I'd ask them questions and make them. If you say, I want some wood dust monitoring done, for example, and they say, yeah, I can do that, we'll say, send me some work that you've done. And if they don't, then they're obviously not as competent in that as they can, and they move on to somebody else. But ask them about the qualifications. It's really important to make sure your people are paying good money for this and they're getting the right service, because at the end of the day, the law will come against the duty holder and say, you never got competence advice. We will take action against the people who are claiming to be competent as well. So that's just a reiteration of what I've said. Make sure you get the help that you need. So in the reports, make sure it says what you want it to do. If you're contracting a hygienist, make sure you're getting what you ask for, not just a generic cut and paste of HSE guidance and then the last paragraph saying, but if it doesn't work, use PPE. That tends to be what happens quite a lot, and that's not really what you want. It's all right to mention it in there as long as they've considered other control options first and they've done enough. They've done enough work to evaluate any exposures to whatever substance it is. So COVID, I mentioned it earlier on, COVID-19 and HSE. COVID-19 and HSE and hygienists, really how we've been involved. I've just took a snapshot of the HSE webpage, and there's lots of things on there which I personally have been involved with, and HSE and a lot of the hygiene team. We've been snowed under really, and over the past 18 months dealing with producing new guidance. One of the things, I suppose I didn't mention face fit testing, but face coverings and face masks is huge. And I was on the pandemic the emergency task unit I don't know whether anybody knows too much about this, but obviously with lots of RPE, everybody wants an RPE coming into the country. There wasn't enough RPE there wasn't enough RPE in the UK to support the NHS. So it's got to go through a long, confusing process to get a CE mark and to get it approved onto the UK market. So there was the government put into, with help of HSE, sort of driven by HSE, put in provisions to basically shortcut the CE marking of any RPE that was coming into the UK. And this led to lots of people, lots of countries sending in RPE that was just fake and it was just poor. And we had warehouses down in Daventry, which, 70 million pieces of RPE, some that were due to go straight to the NHS and probably would have got there because they were good fakes. And so we set up this task force to basically look at it, to ask some questions, to check it was okay before our frontline NHS could use it. And that was really, it was a feel-good sort of piece of work that you were helping the NHS, but it opened a lot of people's eyes as to how the NHS procure protective equipment, how they use it, especially these face coverings, these face masks, these respirators, and how many have sneaked through in the past. So it was really interesting. It was a lot of work, and there were so many applications, and lots of them from all over the country. China was the major one, was sending in thousands, and we were just trying to stop things sneaking through to protect the frontline workers. We also looked at ventilation and air conditioning, obviously, and cleaning, hygiene, and HSE did a lot of spot checks on COVID, risk assessments in companies, going around to check that everyone was getting back to work or trying to get people back to work. Could you work safely? Social distances with increased ventilation and then the correct PPE. And thankfully, the country did start to get back to the working ways. Some things have changed. People might agree or disagree, but some things have changed for the better. I mean, I was never one to be standing too close to too many people in a room anyway, and that seems to have ended. So I consider that a plus point. As I said earlier, I've done a lot of offshore work, so COVID-19 and HSE and oil rigs. So I've been going over to a lot of the oil rigs this year, over the past 18 months, and the first thing a hygienist, the industrial hygienist, as soon as I get on the helicopter, is to look at the COVID risk assessment, because as you can appreciate, COVID onshore is different. COVID is not different, but the control of COVID onshore is different to the control of COVID offshore, because you're stuck in the middle of the sea and you're all living together, basically on top of each other. So How do they control that spread? And so there's lots of ways that the industry have worked really well, in my opinion, with HSE, with other hygienists, with consultants and other health professionals to find out how we can best do this. And I don't know whether I've got a slide on too many of the things that we did or that were done, but obviously testing was a big thing. So you have to, I'm going again next week, and you have to go to the majority of the times you have to go to a hotel the night before you take off, have a PCR test, isolate in your hotel, get on your helicopter. If you've passed your PCR test, go and do, we only go out for a couple of days, but the guys are going out there, they're going out for 2 or 3 weeks. And if you pass it, then you're okay to go out there. But they have still had outbreaks out there because there's so many people, different flights coming in at different times from different countries, which is a big issue because different countries have different rules. So they're now testing while you're out there. Testing is not mandatory. HSE didn't say you have to test. One of the reasons being nobody's sure which is the best test. So we couldn't really support one type method of testing. That was one of the control options that they did there. They also down-manned, got rid of a lot of people out there to allow people not to have to share cabins, because you tend to have to share cabins. So that's pre-mobilisation testing, segregation, so keeping people separate, don't having too many people in the meeting rooms, don't having people in the restaurants, one-way systems, lots and lots of cleaning. Arguably the most important people during COVID offshore were the stewards, the cleaning staff, because they're constantly cleaning things, constantly walking around, doing laps of the site, touch points everywhere. Offshore, they have to have isolation. That's how isolation points work, like a medical unit where you can go if you get symptoms, then you kind of get put in a room with the correct provisions to see if you get any worse, and then you're shipped off, or well, you're not shipped off, you're taken off on a helicopter. Then you've got to identify all your category Bs, which are the people who've been in close contact with you, and then they tend to be taken off as well. It's easing now, but we're still getting lots of cases of COVID offshore. But I mean, it's far more mild, and it's far more treatable, and most people have had the vaccination. If there was an evacuation, they had to have a provision in place for a full evacuation, but that hasn't happened, such work. They've had to remove a lot of people early on because there was a bit of a panic going on. Vaccination have put on the end though, because the industry are pushing for HSE and others to make vaccinations compulsory and mandatory. We can't, we won't, because it isn't. People have human rights, and you don't have to be vaccinated if you don't want, and that's people's own vision. I know some offshore companies have kind of, if you haven't been vaccinated, then they make you isolate for 5 days before you go. So they're kind of pushing you to be vaccinated, but that's up to them. So from the pandemic, this is just a quote that BOHS use, HSE use. So the Health Service Investigation Branch, HSIBI, did a report on nosocomial transmission of COVID in hospitals. And they concluded that the management of the risk highlights their safety observations and a number of areas which directly reflect the absence of expert knowledge that can be brought by the occupational hygienist. As an occupational hygienist, that gives you a bit of a warm blow, to be honest. But they should have done more. They should have done more. People just haven't assessed the risks for something like this happening. And you'd think they should really. This can happen. Infectious diseases can happen, but without the expertise of somebody like an occupational hygienist, or somebody knows how to assess risk, then it may have been easier. There may have been less infections, etc. But we'll never know. So somebody will probably come up with a figure one day, but that's not going to be me. So what do? I'll just give a bit as a hygienist. So investigations within HSE. One of our tools that you might see as a hygienist use, and how we can assess. I mean, because I think a few of the words in the title of the advert for this was how can a hygienist improve worker exposure in the workplace. And investigations and evaluations are kind of I don't tend to go around and do risk assessment for people, but we investigate them if there's an issue. The use of a dust lamp, and I think a few hygienists might be, I'm sure I've seen Adele pop up there. She's a fellow hygienist, and she'll be more than familiar with the dust lamp as a good tool. This is an example of some backlighting and a dust lamp. With a guy doing some soldering. If you turn that light off, you don't see that fume. But if you put the dust lamp on in the right place and take a picture, you can see it. That fume is, it's up and around his breathing zone. So this is how we evaluate any potential. If you go into a workplace, it's nice and bright and you can't see anything, that doesn't necessarily mean there's no fine fumes or anything around the breathing zone. He's got a respirator on, looks to be fitted okay. Well, I know it is because I think it's an HSE picture. Water dust lamp, that's what we'll use. Earth sampling, that's a hygienist will often come around and take earth samples, fitting into the lapels of people or doing static samples to get a quantitative figure of how much of hazardous substances in the environment or in the work zone. You don't need to, I'll say on earth sampling, some people, they get nicknamed pump jockeys at the time who just stick sampling pumps on everyone. If you walk in somewhere, as a rule of thumb, if you can see a load of dust, then you don't really need to sample because you'll be above any level anyway. If you can see it, you're above. Don't bother. Just work on your controls. Try and get rid of that. Biological monitoring: urine or blood. Blood for lead, typically. Urine, an example is isocyanates. It's the only real way to detect if people. You can do earth sampling for isocyanates, but it's a bit fiddly, to be honest, and I'm not sure what it shows you. So people are using isocyanate spray, and then they need biological monitoring, which is a urine sample to see if it's been taken up by the body. It's excreted quite quickly, but you can monitor whether the controls are working effectively. So it's required for certain substances like isocyanates. Observations is the big thing. Observations, as I mentioned, walking around. If you're going to do a survey, or if anyone's doing a survey, go around and have a look at what the process is and where the nasties are coming from. Can they be engineered out? Can they be removed? Do we need to do this? Can they be damped down so it's not in the air, we're not breathing it? Can things be wiped up? What PPE will we need? Is the PPE being worn correctly? Is the RPE being worn correctly? Is it being stored correctly, etc.? I also deal with fatalities. So this is a relatively recent case that I dealt with as a hygienist. We were really, the hygienist was pivotal in the outcome of this case, and it was a local authority issue. I can talk about it now because it's been through the courts. It went through the courts finally in January this year. Briefly, what happened, that's a generator, if anybody recognises it. Generators pump out with other things, carbon monoxide. So this is in a store, in a room at the back of a shop, a convenience store. Above the store was some rooms to let, some bedrooms and a shared kitchen and bathroom. Basically what happened is this generator had been left to run inside, and the guy in the room directly above, I don't know if you can see the labelling too well on that, he died. So the white building at the bottom is where the generator was. That was the guy's bedroom. He died of carbon monoxide poisoning. So I was asked to go there to help the local authority quite quickly and the police. And we did some tests to see what we were looking for was a pathway. So an exposure pathway. Can fume from there get into that bedroom? So we did some tracer gases, released some tracer gases at the same rate as a generator, and then put a detector in the room, and it was conclusive that they can. So the gas can get from A to B. So carbon monoxide can get from A to B, and unfortunately it killed the guy who was in his room. This has resulted in a prosecution. I've been involved in quite a lot of prosecutions. This is the most serious one, or the most significant and poignant punishment. So there was two defendants involved in this case. One was the landlord of the building who owned the store downstairs and owned the flats above, or the rooms above. One was the shop owner who rented the store, and he was the guy who got the generator. And they ended up with, they got 8 and 9 years in jail, respectively. I'm not sure which one got which, but I think the landlord got the 9 years. So it's a significant input of a exposure control expert witness, which in that case, in that instance, was me. This is why I'm allowed to talk about it. But this is what can happen. I mean, the poor guy just died because going to sleep upstairs, and that's completely wrong. And I think the punishment was it's no consolation to his family, but it was a decent sentence. So, excuse me. Conclusions about hygienists. I've got some bump to talk about just after this on BOHS, but I'll be nearly done then. So what do hygienists do? Scientific specialists who practice. We positively influence the overall health protection on staff. So that's what we try to do. We improve the health of staff by not letting their health be deteriorated, be affected. So that's how it's very difficult to measure, but that's what we try to do, and that's what we aim to do. We have an understanding between engineering management and technical controls. And so you get a lot of hygienists who come from an engineering background who understand control systems. I'm a chemist by trade, so I understand chemicals and the health effects associated with them. And the exposure scenarios, which is what we assess a hygienist, a consultant hygienist, will go and have a look and assess the exposure scenario. I'll probably go and have a look and see how they've assessed it. So we balance risk, regulation and reality can reduce the burden on managers and enable focus on core and critical issues. So if you get rid of the exposure to health, etc., or you can control it, then you can work better to focus other areas. Some parts of health control, of health exposure control, are really simple. They just don't get done, and there's just cut corners. I'm hoping that conversely, COVID will have a good effect, and it's really put health on the map at the minute. BOHS, I'll just quickly touch on what BOHS are, in case nobody knows about it. We're an authority in looking after BOHS. We're in Hygienist, founded in the 50s, science-based charitable body, and we're a chartered body, and we look after all the hygienists, and plus we try to get out there and speak to other people as well. Our mission is to safeguard the UK's future health and effective management. That's what we try to do, and our vision is to reduce chronic ill health and acute or chronic ill health, so short-term ill health or long-term, long latency, 30 years after exposure. Asbestos being the primary example. Our vision is to have a future where things like that don't happen anymore, but unfortunately they probably will, but we've got to reduce it as much as we can. Want to get rid of harmful exposure, substitute hazards, the hierarchy of control, design out threats if possible. If you can design it out, there's been another good way of designing out was flour dust, which I mentioned earlier. You can now get dust-free flour because obviously flour dust is an aspergen. So if you're breathing in flour quite a lot, I've been to lots of bakeries where there's flour dust all over the place and people don't realise what the health effects are. You can now get dust-free flour, so you don't breathe it in. Basically, it's coated in a little bit of oil. Problem being, it's more expensive. So you've got to manage out whether that's the right option to go down. So we want to ensure that everyone in work has the right protection at the right time. So are the controls working when they need them to be? We're a membership organisation, so we have faculty membership. I'm a chartered member. We have an asbestos assessment and management faculty, which I believe is quite hard to get into. I'm not a member of that, but I don't have too much to do with asbestos these days. But there's other routes to go in there. There's lots of qualifications for LEV and being one of the things that courses that BOHS runs. So have a look on the website for all those. A lot of campaigns, Breathe Freely in construction, you might have heard of, you might have attended, hopefully you have. Breathe Freely in manufacturing, welding being a big issue at the minute, so that's involved in there. Conference was last week, the week before I went to, and it was the first face-to-face one we've had for a couple of years, and it was really good. I was only there a day, but I found it, the talking to people was probably, in between presentations was priceless, really. You learned a lot of things. We have an academic journal that people can have a look at and read if you'd like to. And we represent government regulators, me being one anyway. Okay, so I think that's pretty much my presentation. Have we got any questions that anyone would like to ask? I've no idea what time it is. There you go.
Thanks, Phil. That's great. Yeah, we've had a few questions coming in the chat. So if anybody's got any more questions, put them in the chat. But one question, and it's been sort of repeated again, was, has a HSE been doing any work on the effects of the lost change of taste and smell? This is like thinking COVID related, into distinctive tastes and smells of hazardous substances, and not be able to sort of notice like a gas leak or a chemical leak.
Yeah, I think we have Science Division, which is our branch up in Buxton. They were involved in SAGE and all sorts, and so they've been involved in numerous research reports. I don't know whether they've actually looked at that. That was mentioned quite early on. Somebody mentioned that, who I thought was quite forward thinking, to say, well, if you've lost your sense of smell, how can you smell if something's leaking? Which is a very good point. As a hygienist, as a control specialist, what you should be saying is, well, it shouldn't be leaking. But however it will, you shouldn't rely on people having to smell or taste things to control exposure. But I think I've got a feeling there is some research, but I wouldn't know who's doing that. I don't know whether HSE would be doing it. Science Division have a commercial wing to them, so they get paid to do certain things. They might be doing it via that route for the government. But if you go onto the HSL website, you can find out more information there. I can certainly ask the question if you'd like me to feedback.
That'd be good. Because it's another related question to that, saying, if people are doing face fit testing and they're doing it through like the taste and smell, obviously that's not going to be applicable, is it?
Well, you do, when you do a face fit test, you have either Bitrex or saccharin. So Bitrex stinks and, well, sorry, tastes horrible. Saccharin's just really sweet, and you do a sensitivity test before you do the test anyway. If you're relying on a qualitative test, so you spray a little bit into the hood, and if they sort of screw the face up, then they can taste it. If they don't, then they can't taste it. And you do the same with saccharin, and if they can't taste it or they can't smell it, then they can't be done a qualitative test. So they have to do a quantitative test then, which is counting.
Somebody did put that in the chat actually about doing a quantitative test.
Yeah, that's what you'd have to do.
Yeah.
You have to go down that route.
Yeah. I've got another question here, just with regards vibration monitoring. So what is the HSE's view on extensive vibration monitoring should be? So they have one vibration monitor, and we use the data building it up on a log for real exposure to help with future risk assessments. Operatives thought to be at risk are issued with the Have Watch that links to a smart chip on each worker tools. The tools have been subject to sample monitoring with vibration monitoring equipment, and we can track using the app. I just wonder whether you've got any views on it.
Well, I think my noise and vibration colleagues will have a view on that. I know about these gloves and these active monitoring things, and it's vibration, as with vibration exposure, is to do with your points on the ready retina and how much exposure you can undertake during one sitting, so you don't go over the points. But as long as all this control and measurement system is linked together, and you get a conclusive sort of number and a reading at the end of it, then it can be used as your exposure control. But I've got a funny feeling there's something to do with this watch and glove that there's a little bit, maybe it's not as good as people think. I could certainly have to put that onto a vibration expert, really.
Okay. Another question is, does a HCC workplace wellbeing training as part of their remit?
Wellbeing training?
Yeah.
If it assists in the protection of health at work, then yeah, it is something we ask about. And I think this year, on the strategy, I think for HSE, there's a focus on mental health and well-being this year, so it is certainly something that we ask. I know our general inspectors go out, and when they go out on inspections, they talk to people about well-being, mental and physical well-being on the workplace. So it is something that HSE are concerned with, because it is included in the regulations and the law that you must have to look after your workers. Oh,
hello.
Oh, hi, Andrea.
Hello.
Thanks for joining us. I've just got another question here. So BOHS, have they got any generic advice on future pandemics? But I mean, I know myself that early doors of the COVID, I did use a lot of information that was on the BOHS website, and I know there is lots of information, and you don't have to be a member to get to that information, do you?
No, you don't. You just have to go onto the website and search for it, really, and there's plenty there from a COVID point of view that BOHS have been doing, and HSE are doing through Science Division, are doing a lot of research as well. There's lots of, from the offshore work, the offshore got Oil and Gas UK, they're doing loads of stuff on the future of COVID. I think we'll be inundated. I imagine, Carol, if you go to the BOHS conference next year, there'll be a lot of COVID related papers being presented, because everyone is looking at it, because it's, for academics, get the teeth stuck into things like these.
I think what I noticed about the BOHS website is there are a lot of videos as well as presentations on there, so it is worth a look for any safety professionals to look at the BOHS website, because there is quite a lot of free material on there, and like old presentations, which is still quite relevant.
Yeah, I mean, that's what it's really useful to go through and have a look at that. So I'd advise anyone to just have a little, if you've got 10 minutes to have a nosy through there. It sometimes takes a bit of getting used to, like most websites, but once you know where you're going to and you can bookmark it, you can find quite a lot of things.
Okay, and the last question I've got for you is, how big of an issue is the competency of hygienists across the UK? And have you identified any major issues as a result of incorrect monitoring or incorrect advice? Yeah,
it's a big issue, and it's Andrew will surely support me on this one anyway. We come across, I mentioned it in the talk, that there's lots of people who've been getting away with it for years. If they've been giving poor advice with regards to, for example, if you wanted an example, when they do some monitoring, putting the samplers on the wrong people. We've had, for example, we've had welders who've been welding. I look at the welding report when I go there, and they say, oh, everything's below the limits. And then I say, who did you fit it to? And they're fitting it to staff who aren't doing any welding. So they're not fitting it to the people who are getting the most exposure, and they're not monitoring them. A lot of them don't take, a lot of the poor ones don't make any real observations. What I'm supposed to be able to do if I go in and look at the report, I'm supposed to be able to see what was happening on that day, see who was where and what they were doing, and often there's not enough contextual advice in there or information in there to replicate what they were doing. But I don't want it to, I think we should emphasise that there's so many good hygienists about, that they shouldn't all be tarnished with the same brush, because the problem we have in at the minute, because I mentioned earlier, there's not as many hygienists in the UK. They're really busy. All the good ones are really busy. If you get one who isn't doing any work, I'd be asking them another question to see why they're not too busy. But yeah, so it is getting, to answer the question, it's not getting worse. It's just that HSE are looking at it more now, and we're taking more action. And the action that we're taking does seem to be having, it's early days, but it does seem to be having an effect, because words are getting around that HSE won't let you get away with this for too long.
One thing I've noticed is that when people do reports, so they'll get the company in, and then what you find is a very junior member of that company, they might not even be a member of BOHS, has gone out and done the sampling, and there isn't enough contextual information to back up what that result means. So when it gets back to the company, they can't really do anything with it. And when you actually ask questions, you say, well, when this person asked for you to come out, they wanted you, not a junior member of staff. So just be very careful of that as well. And also, people go out and say they're part of BOHS and they're not, and we can check. And we've kind of had quite a few people who say they are and they're not.
Yeah.
So if you do have people who you want to question that, you can email BOHS and ask the question. Yeah,
it's a good point, Andrew, because you do see this, such and such has come out and give you a quote for the work, and then a junior trainee has done the actual, and it's not their fault, because they just don't know what they're doing. But you're not, the worker at the end of the day isn't protected as they should be.
Right, I think that's all we've got time for now, but that's been a really good session, so I'll hand over. Are you there, Gary?
Yeah, I'm here. Carol, there was just one final question there. I just think it's about gas safe, and it's about distinctive smells such as gas and mains leaks, and smells from these, so in domestic properties. And the questions around gas safe and the HSE might be interested in the outcomes or an increase in people not being able to smell gas and reporting of sort of gas leaks.
Yeah, I think that probably is going to be a problem, isn't it? Because it's not something I've personally looked at, but it's a consideration that I hope the people who look after gas safety but I mean, the amount of people who are suffering from COVID compared to the amount of people who live in properties that have gas appliances is probably a lot less. That you'd hope there's not going to be that many people who fall into that scenario, but it could happen. So what they're going to do? Is there an alarm on there that'll flash and tell you there's a gas leak instead of just relying on your nose?
Yeah, and obviously gas companies and suppliers might be interested in that as well.
Yeah, I think so.
So that is the end of our session. Thanks very much, Phil.
You're welcome.
Thanks for the cameo, Andrea.
I'm going to go back to bed now.
You timed that perfectly. Yeah, very interesting presentation. Thank you on our behalf, on behalf of everybody that's joined today. Some interesting questions and some good answers that I'm sure people have got a lot to take away.